All right, we'll get started. So welcome everybody to the first of the Chairs Grand Rounds for the academic 23-24 year. I'm Mark Crowther, Chair of the Department of Medicine here at McMaster. We have reduced the number of Chairs Grand Rounds this year to a total of 6. And I'm just going to highlight some people who I think are exceptional examples of what we should be doing as physicians, or people who are really leading the charge. And I am extraordinarily pleased to have the first presenter be Dr. Christian Hunter, who many of us know because of the work that he has done in South Africa, and has done a lot of work with various faculty members here at McMaster, including Dr. Craker, Dr. Fulford, and others. And in chatting before this, I said to Dr. Hunter that he is the primary example of somebody I know who walks the walk. So many of us are involved in working in disadvantaged countries and help with that kind of thing. But Dr. Hunter really invested a lot of his life and his family's life in walking the walk around improving the quality of care for patients in developing nations. And so I'm going to turn it over to him, and I'll be monitoring the question and answers in the chat. If there's any concerns, please bring things up there. This will be recorded and can be viewed afterwards. And then at the end, we'll have time for question and answer. So without further ado, Dr. Hunter.
Good morning. Thank you very much. And I appreciate the opportunity to give this presentation. Why don't we go ahead and start? I'll just share my screen here. So this morning, I wanted to talk about contributing to health training in low and middle income countries. And I want to particularly highlight the collaboration between the University of Namibia, Faculty of Health Sciences, and the McMaster Department of Medicine collaboration, which has been in place now for many years. My name is Christian Hunter. I'm a professor of medicine at Georgetown University, and I also, as of yesterday, am an employee of Abbott Laboratories, where I started as the area cardiac and pulmonary system director for the Americas. I continue as a professor at Georgetown University, and my conflicts are that I'm an employee of Abbott Laboratories, and that's it. So I would like to talk a little bit just about my background and my training, especially for those of you who are in your training now and who are thinking about different pathways forward and ways that you might be able to contribute to health, both domestically and abroad. And it's not a linear path for me. And I found that many people who end up working in areas of service have an unusual pathway, and there's not really a direct training pathway that you would enroll in the very beginning where you say, I want to be a global health practitioner. So I trained in medicine at Loma Linda University, where I had a wonderful experience. I was trained as a physician scientist, and then I trained in internal medicine at the Brigham Women's Hospital in Boston from 2005 to 2008. And then I went to Johns Hopkins for cardiology, where I completed cardiovascular medicine for 4 years there, and another postdoc at the NIH while I was there. And at this time, I was fully engaged as a physician scientist, practicing clinically and working in the lab, developing mostly basic science and translational work. And during this time, I had opportunity to spend some time in Namibia, where my parents have lived and worked for the last 25 years, where they run a school for children who were affected by HIV/AIDS. And as I was visiting my parents there, my father introduced me to the new dean of a medical school that was being started in Namibia. And we'll talk more about Namibia and the landscape there. But Namibia, up until this time, a newly independent country, had one university that had been established after independence, and there was a nursing school, but there was no school, there are no other faculty of health sciences. So there was no medicine, no pharmacy, no physio, no occupational, and there was also no veterinary school. So I was offered the position of being the department head for internal medicine, which I accepted, and my family immediately after finishing cardiovascular fellowship, we packed up and we moved to Namibia, where I was a full-time employee of the University of Namibia, and initially the only member of the Department of Internal Medicine, and the and then quickly became appointed as the head of physiology as our physiologists had left, and there was no remaining people to teach that med physiology training. So from 2012 until 2020, I was a full-time embedded employee there, and I worked to help with the team to set up this School of Medicine, School of Pharmacy, and eventually we added dentistry, physiotherapy, occupational health, and veterinary medicine, which I was not involved in. And then during this time, I became involved and developed a relationship with McMaster University through Professor Christian Craker, Dr. Craker, who contacted me before I arrived in Namibia. After leaving Namibia in 2020, I joined Georgetown University Medical Center, where I'm a professor. And my primary appointment was first at the Center for Global Health Practice and Impact, where I was the Director of Clinical Care, Education, and Research. And this center primarily works in improving the quality of care for people living with HIV, and does direct service delivery throughout Africa, the Caribbean, and domestically. I recently transitioned into the Center for Global Health Science and Security, and became the director of the Global Infectious Disease Master's Program. I'll continue as a part-time in these roles at Georgetown University, but I'm now with Abbott. So it was a circuitous path to end up into global health, and my training was definitely focused more on a straightforward, what I thought would be a career in academic cardiology, but it turned out into something that I found very fulfilling and wonderful. And much of the reason why we were able to be effective in that role was because of the support and the collaboration between the department that I was running and McMaster University, as well as the individuals in the UK and some in the US and Germany and other places who supported us. But this was not something that I ever would have been able to continue if I had not had that support. So I have deep gratitude for that, and not just from the emotional and for the technical support, but just the absolute feeling of walking a path together. And that, when we first went, we were thinking that we would be there for 1 or 2 years. And then it turned out to be a full 9 years that we spent in the country there. And then the last 3 years working throughout low and middle income countries in Africa and abroad. So today, I want to talk about human resources for health in low and middle income countries. And then in particularly where my area of expertise is, the landscape of health training capacity in Southern Africa. And specifically, when I talk about our collaboration, it's not really my story to tell about the establishment of the medical school or the individual doctor's experience, because all I can talk about is what my role was, and that's their story to tell. So at some time, it might be interesting to have some of the Namibian faculty, or perhaps even the graduates, speak to you about their perspective on this, because I'm giving the perspective of somebody who was asked to come in from outside and work alongside the Namibians and the other expats who are there working in support. So after the collaboration, I want to talk a little bit about how this collaboration allowed us to expand our activities beyond just maintaining the minimum workload that we were able to get done with our limited resources, and talk about how some of this mentoring was able to be translated into developing not only the clinical capacity of the university, but also the research capacity, which is ongoing. And this, of course, helps lead to a sustainability around both answering questions that are relevant to the region, as well as developing faculty members to ensure that the training continues after the initial group of people who have set up the faculty, the medical school and other schools. And then finally, in their own words, I'm going to show a short film that we made that highlights, well, it's a documentary about the first Namibian doctors. And then we'll end up with some questions or comments. I'd be really interested in your feedback. And, so I think we're all very aware of health workforce shortages, both in North America. The recent events have left people stretched, people are overworked, people are burnout. And you can hear in the hospitals, in the labs, people feeling that they've just been completely stretched. In my experience in working in Africa in particular, throughout both Southern Africa, West Africa, and East Africa, there continues to be a very, very large shortage in health workforce and resources across all cadres. And this study, which was brief, this is just a brief of the study that was released, but the WHO highlights here that chronic staff shortfalls stifle African health systems. And you can look throughout the region, and I don't expect you to have to read this now, but I've included the link here below if you'd like to scrutinize it, if you're interested in more. But except for 4 countries in the region, the staffing ratio of the WHO threshold density of health workers per 1,000 people needed to deliver essential services is low. And I'm happy to see that Namibia is now one of those 4 countries that does meet those staffing minimums. However, those staffing minimums don't truly reflect the regional distribution of healthcare workers. So this health worker shortage is longstanding. The study cites several factors, including inadequate training capacity, rapid population growth, international migration, governance issues, career changes, and poor retention, which is something I saw a lot of. These are very challenging systems to work in. I'm sure in your hospitals you've been dealing with issues around retention after the pandemic. But in these health systems, the day-to-day conditions are difficult to the point where it makes it many people burn out. And then finally, the study says to reinforce the health system, it's critical to address the permanent shortages and poor distribution of health workforce. And this is an easy thing to say, but the reality is that even investing now, there's going to be a long-standing shortage in healthcare workforce. And so while it's critical to invest now, we also need to think about how to bridge the gap. So, I want to talk about how we did this in one instance, in one example. So Nigel Crisp in 2011 summarized a larger report that was written talking about global health workforce capacity and turning it upside down. And one of the things I really appreciate about this article is it talks about how much we have to learn from health workers and health workforce in these low and middle income countries who have been working under extreme conditions. And in this graph, which I'm sure we're all familiar with these type of data, but we know that North America contains 5% of the world population, about 3% of the burden of disease. We have 25% of the healthcare resources and 30% of the health workers. In sub-Saharan Africa, which is rapidly growing, there are about 10% of the world's population. This was 10, 12, 13 years ago. At the time, 25% of the burden of disease and only 3% of the healthcare resources and 1% of healthcare workers. And so what we have here is a maldistribution that would have been preventable and it needs to be adjusted. So he puts together a graph here where he shows aligning with the Millennium Development Goals, what the key enablers, the scale-up outcomes, and the quick and medium and long-term goals are. And I would say that one of the issues that we have in global health and perhaps funding in general is that often we look at 5-year or 3-year time cycles, which most funding programs are aligned on. And so when you're talking about investing into a 30 to 50-year investment, it's often hard to pitch that to funders or to find funding announcements that will support that type of activity. But obviously, we need to have better infrastructure. We need to have more community health workers, better system management, and then curriculum reform, and et cetera, et cetera. So this is a long-term engagement that needs to happen. And this has been driven internally by local healthcare leaders there. This is not a prescription from outside, but it does reflect a rational, but very long-term and very investment-heavy approach to this. Annals of Medicine and Surgery. Which we'll share the link here with you, the complete reference, which I believe I left off here. Published recently, where the number of medical schools, they did a survey looking at the number of medical schools throughout the regions in Africa and the estimated populations, and looked at the number of medical schools per population. And what we see here across the board, except in Northern Africa, which has a higher proportion of medical schools, there's a very low proportion to the number of medical schools. And so not only do we see or people report gaps in their capacity at their local medical schools, there's also a great need to increase the number of medical schools. And to start a medical school, it requires a huge amount of investment. It requires national commitment. It requires commitment from key stakeholders, and it's not something that's easy to set up or to sustain. So this is a huge challenge. This is a very extensive report that was published in Human Resources for Health in 2012. This was a survey that was done over 10 years ago now, which I encourage you to read. I've got the reference here. But this is the most extensive survey that I've read, which looks across medical schools in sub-Saharan Africa, looks at key issues driving both the quality, issues driving retention of staff, quality of education there, the recruitment of qualified students. And as you can see, this is figure 20. It's a very extensive, long paper, which carefully lays out in sophisticated detail many of the complex issues. I just wanted to highlight here, if we look between not being a barrier and severe barrier, with 0 being no barrier at all, and 4 being an insurmountable barrier. If we look at the barriers to increasing the number of medical school graduates, we don't have a barrier here around insufficient qualified students. And that is something that I was so blessed, and I feel so grateful, was the opportunity to be able to work with these students and the faculty, because the amount of talent that is there makes me incredibly optimistic that despite all of these challenges, there is a wonderful resource of talent and people who are intensely interested and invested and seeing change and affecting change in their own neighborhoods, in their own areas of where they grew up. And I believe strongly that the people who are affected by problems are going to be the ones who are most likely to be able to come up with sustainable and innovative solutions. But there are barriers for this, and those include training, access to training, and also access to resources. So the number one barrier is not having students who are qualified. Although all of us would agree, and maybe in particular, there's been a national movement to really increase the quality of school and nutrition all the way from that first 1,000 days that we know is so important, all the way to secondary education. So that's a long-term investment that needs to continue. But what we do have is we have wonderful resources, people who are ready to step into the gap and ready to engage in long, grueling training that will not reimburse them personally as well as you would expect if you, or perhaps to go into a capitalist-driven society where you're in fee for service. But what are the barriers? Well, the barriers are, number one is poor salaries for teaching staff. And it's very, very hard to retain people when they're struggling to be able to support their obligations. And there's also insufficient basic scientists to recruit as well. Much of the research, and this is a different lecture entirely, but the research capacity in Africa has been growing in sub-Saharan Africa. I'm talking about particularly, but we see that much of this is done through collaborations with Western organizations. And much of these are driven by Western priorities. And so the training of local scientists and clinical researchers often is, it's complicated, and we often don't see the opportunity being given for people to truly be mentored into a leadership position. And so having basic science capacity there to be able to teach the physiology, teach the pharmacology needs to be increased. So there are insufficient teaching resources, but people are able to overcome that. But it is a significant barrier. And this is in particular where McMaster University was able to support me. And I'll talk about some of the other issues too. But initially, I was responsible for teaching 5 modules of internal medicine. And these are, in most cases, year-long modules where we're giving multiple block tests throughout the year. We're giving lectures spanning internal medicine, as well as developing an assessment strategy, both performative and summative assessment, making sure that we are evaluating people and make sure that they have the minimum competence needed to move forward. And when you just think about writing the number of questions that need to be written, it becomes very difficult to provide quality assessment that is blueprinted to the course that you're teaching, as well as it is very difficult to come up with lectures outside of your area of perhaps training, which all of us have areas where we feel more comfortable in teaching than others. I was very stretched, and it was good for me, but that lack of resources of being able to reach over and to call somebody from the department to give a lecture about plasma cell dyscrasia may not be there. And so McMaster both provided support around assessment, as well as mentoring around how to provide effective assessment, as well as providing teaching. Some of the other things that are highlighted are insufficient funding for clinical teaching positions, and that's a major barrier as well. And then the number of doctors that are available to be recruited into clinical faculty, especially in systems where there's public and private healthcare, such as Namibia and South Africa. If you're a physician or you're a specialist and you might be qualified to teach, you are much more likely to be able to make a more lucrative salary in private practice. So the realities of being able to recruit people into positions that are lower paid is a severe barrier. But I think the main issue here is that we don't have a shortage or there's not a shortage of qualified applicants. There's a shortage in effective barriers that can be fixed. So this is from your website, and this is highlighting the McMaster University of Namibia collaboration, which has been ongoing since October 2012, which I arrived in the country in July. And this was led by Professor Dr. Christian Kraker, myself from the University of Namibia, Dr. Sheikh Zain Chagla, and many others, including the Department of Emergency Medicine, contributed, and many people throughout the administrative and technical cadres. So it was supporting an undergraduate medicine training program, although it ended up to extend our physiology department as well. We taught the basic science of physiology for 1 year, as well as pathophysiology. And we got great support from McMaster around that as well. The curriculum development around internal medicine, tropical medicine, HIV, TB, and malaria was there, as well as just the basic day-to-day bread and butter of internal medicine. They supported research. This collaboration supported research primarily through mentoring, although there was some financial support for some research projects as well. And SANE, for instance, was able to source us with some point-of-care tests for hepatitis B, antigen, and also for some Cephia Gene Expert cartridges. And so this connection really did catalyze student research as well. And then evaluation, design, and implementation. And one thing that I was struck by when I arrived there was the lack of training that I had received that would allow me to be confident in a position when you come into a teaching position after training in basic science and clinical medicine. While I had been subjected to assessment and we had learned about the approach that we were going to be assessed under, I had no real idea about how to set up a curriculum that was synchronized with assessment, that was objective and structured, and would allow us to be able to fairly and accurately judge whether or not somebody had met the minimum criteria. And then clinical bedside teaching. And then there was some cross collaboration. Two Namibian medical students were able to come to McMaster for a rotation that was incredibly fulfilling for them. And I think for many people at the hospitals there that benefited from getting to know them. So Namibia and Southern Africa, adjacent to South Africa, to Botswana, Angola, Zambia, and Zimbabwe. Many of you may have heard of Victoria Falls, which is a point where all of these countries come together. Namibia is a beautiful country. It's vast, it's arid, and it's very lightly populated, which while the population is low because it's distributed, it's difficult to have a concentrated healthcare system. You cannot have a centralized healthcare system there to meet the needs of the population. So from the BBC, just for those of us who haven't maybe studied this, Namibia, as I mentioned, it's vast. There's over 800,000 square kilometers. And I believe this is about right. There's about 2.5 million people. This was this July. The capital is Windhoek, which is in the center of the country. And there are many languages there. English is the spoken language, but Afrikaans, Oshawamo, Damramama, and many other languages are spoken throughout the country, which increases the need to make sure that the trainees that were selected in a way that reflects the population. The life expectancy has improved with the introduction of structured antiretroviral therapy for HIV, but is still low, around 60 for men and 67 for women. Namibia gained independence from South Africa after a long political and military struggle in 1990, and has developed a what I would say is a very stable government, and has not been struck with some of the violence and other issues that have dealt with in other countries in the region. So the number of doctors per 1,000 people, this is from the same website, but the source is the WHO. And Namibia is 0.4, which does reach the threshold. But if you look throughout in the other regions, South Africa is 0.8, which has a very large population. Zambia, 0.2, for context. So this is an older map that was drawn by John Mendelsohn and his colleagues in the Atlas of Namibia, which is it's a beautiful and very helpful document. It's published by the Central Bureau of Statistics. This is a decade old. There's an updated map with the color scheme on this. I think it's easier to understand. But you can see that the highest density of the population is along the Angolan border there. And there is a lot of cross-border traffic, as you would imagine, meaning that there needs to be a strong collaboration between the two nations, which has been quite good. And so there are regular meetings across the ministries at border health stations to address that. But the vast majority of the population is concentrated there. But as you can see, there are people scattered throughout the country. And because of the large area and the low population, this means that even though there are healthcare workers that meet minimum thresholds, that much of the country is uncovered and it's a maldistribution of that threshold. So it doesn't reflect what you see. There may be enough doctors in Windhoek and perhaps in Anishinabe, although the number of specialists is far too low. If you're in Marienthal, which is in the south, there will be very few physicians. That is, you can see reflection in the health outcomes as well. So the university started the Faculty of Health Sciences it was actually a university in 1992, and the Faculty of Health Sciences and Veterinary Medicine, this is from the University of Namibia or UNAM website, has reorganized into health sciences and veterinary medicine. And it's quite amazing to see what they've achieved now. There's a School of Allied Sciences, a School of Dentistry, which I believe they just graduated their first class this year. Speaking of direction, the School of Medicine, the School of Nursing and Public Health, which was the first school and really was they referred to it in the Faculty of Health Sciences as the mother school. And so nursing and public health were forged ahead first and developed capacity around nursing. And then that was followed by pharmacy, which graduated the first class, and medicine. And now there's also veterinary medicine too. And there's been an increasing focus in the region and in the Faculty of Health Sciences around the concept of One Health, which is exciting to see that veterinary medicine and health sciences are grouped together. They are overlapping, and that allows for some real thoughtfulness around human, animal, climate change, agricultural, and laboratory approaches to health, rather than just saying it's going to be medicine or veterinary, removing those artificial separations. So again, from the UNAM website, School of Medicine opened in 2010. I joined them in 2012, halfway through 2012. And as of last year, it has graduated 400 medical doctors. And I don't have hard statistics on this, but this is close to accurate. I would say, as opposed in some other countries, the vast majority of these doctors have remained in Namibia. Over 90% of them, closer to 95% of them, have remained in Namibia. Those that have left, many of them are training in South Africa and other places. They're subspecialty training, and it's exciting to see because they're beginning to come back now. One of our first graduates several years ago qualified in general surgery. There's now an anesthesia postgraduate program in Namibia. And of the doctors who have stayed in the country, the vast majority of them have stayed in public service. So they've stayed in the Ministry of Health. And part of that, I believe, is because of the way that the Namibian leadership developed the selection criteria, where they looked at the 13 regions and they took graduates out of each of those 13 regions. And so many of the people who were drawn into this program had a deep desire to go back and affect their communities. So there were people who were able to go back and embed back into their own communities and practice, and to speak in their home language to their patients. And the Ministry of Health also, while the working conditions is often described as difficult and challenging, they paid the doctors more than other countries in the region, and they provided them study and education benefit. And that's not necessarily my story to tell, but I think it is a good case study of retention there. So of these 400 doctors, the majority of them have stayed in Namibia, and many of them have stayed and the most of them have stayed in public service, which is very gratifying because this was set up by Namibian leadership to address an internal health concern. And it's wonderful to see that after almost a decade and a half of investment, this long-term thoughtfulness is beginning to pay off. And these graduates will then become the leaders of future training and innovation in the area. And of course, I don't have the numbers for the other schools, but they parallel. Now, there are some of the graduates who are in the UK studying right now. There's several in the US. Several of them are looking for other opportunities for postgraduate education, and some may actually immigrate. But I think it's wonderful to see that that they've been able to go and reach postgraduate training outside of Namibia, and they've been welcomed and seem to be as confident working alongside. And that's, I think, further emboldened the project because our graduates have been well received in postgraduate programs. Yep. One of the unique opportunities that the Namibian leadership provided was, instead of having a centralized system where everybody came to Windhoek or to Oshakati, which is in the north there, having two campuses, they've distributed campuses throughout the country. And when the leadership started the medical school, a key part of this was a community-based medicine rotations. And so students would then be located and sent throughout all 13 districts and regions through the country where they were embedded in local health systems. And this was wonderful because they often, it was designed so they didn't go back to their home region. And so they're able to experience other cultures and other health systems. And I think this has contributed in part to the willingness of some of the graduates to go out to these more remote outposts. So being able to set up training centers throughout the country has allowed them to be able to increase their long-term infrastructure for sustainability of a distributed health system. So there's tremendous pride in the country. This is from New Era Live, which is one of the local newspapers, and this is one of the buildings in the back you can see here. And one of the things that I can say that I think has really helped lead towards the success of this endeavor is that there was an incredible investment by the government into the infrastructure of the endeavor. And so when the faculty were set up and embedded there, the buildings, the laboratories, all of these facilities there, they had been invested. And that really gave a clear signal that the government was serious about this project. They invested money on it. They had not relied only on outside funders, because if it's outside funding mechanism that for some reason gets halted, then the project ends. And so so they have invested in that infrastructure, not just in Windhoek, but throughout the country. And it's been, I would say it was more challenging to find faculty that were able to work than the infrastructure. So there's tremendous pride in both the institution and then seeing that there are Namibian trained doctors after so quickly after obtaining independence from a very long struggle for right. You can see highlighted in the BBC, Dr. Lucky Marangi, as he goes by. He's also recently, except 3 years ago, qualified as a general surgeon, but he was one of the first graduates and that was trained and he gave a very nice interview in this article here. And his perspective was really, I learned a lot from him. And he is a leader in the field now, and is a mentor to many people. So specifically, internal medicine and physiology. When I joined, there was nobody in the Department of Internal Medicine full time, and it had been taught by two people in a part-time manner. One of them was Professor Humphrey Hodgson, who is an internal medicine and gastroenterologist and physician scientist from the UK, and he had been asked circuitously to come with his wife, Professor Shirley Hodgson, who's a geneticist and pediatrician, to consider coming to Namibia and contributing. And him and his wife, starting, I think in 2010, came for the next 10 to 11 years, 2 to 3 times a year, for perhaps 6 months, 6 weeks or longer at a time. And Humphrey, along with the local part-time clinicians, was responsible for setting up the department. He's extremely experienced in not only clinical medicine, but also in understanding how to develop a curricula and how to implement the curriculum, which I learned is a big difference. Having a curriculum and implementing the curriculum are two very different things. And also his expertise around assessment. And both him and Shirley, they became mentors to me, and they invested huge amounts of personal time and personal finances to be able to do this, with essentially no reason to do so besides the fact that they saw a need. And I think they had a really long-term perspective on this effort, and I'm deeply appreciative to them for their mentorship. Also, Christian Craker from McMaster, who had recently completed his training at the London School of Hygiene and Tropical Medicine, his master's degree, had done a project there and had been invited to come to Namibia. And when he was there, he worked along with Humphrey and had been teaching, and I did some research, which I'll highlight, which very much influenced our approach. And he, so this is Humphrey and Shirley, who are wonderful people, and really have steel in their backbone and a willingness to continue to give without reward. So before I arrived, I received this email from Christian Craker. I redacted his email address, but I'm sure you can find it. And this was July 19th, 2012. I think I left the week afterwards, just finished cardiology fellowship. And I think this email kind of summarizes the whole approach to how Christian thought about supporting us. He introduced himself. He said that he, had been informed that I'll be moving there, and he and Humphrey had been doing the didactic training, and he had committed to come back for 5 to 6 weeks, and he had sought out resources to bring trainees to help with teaching. But what he did is he didn't say, we're doing this and we're coming here. He asked if it would be okay with me, and to let me know what he thought. Now, of course, I wasn't the boss at that time or ever, but I was just struck by the humility of this and really encouraged. And so he had this attitude through the whole way, through the relationship, and still continues to do so, which is essentially saying, do you have any needs that could be met, or is there any way we can help? And this is markedly different than some other collaborations that I've had where people came and said, we're going to help you. Hold on. And so on the right here is Christian Craker doing some bedside training, teaching on the wards, the general internal medicine wards at the Canada State Hospital. which was our large teaching hospital. It was a state hospital, was not set up as a teaching hospital, but has, along with collaboration with the Ministry of Health, become one of the main teaching hospitals, as well as the Shakati in the north and the Rumbu Hospital. On the left here, we see Humphrey during in our wonderful clinical simulation room, which had been set up where we were able to perform our objective structured clinical examinations with Anel Zietsman on the right, who's a Namibian oncologist, and Liz Selden, who's a internal medicine professor from Georgetown, who also came. Christian Craker and I working together and also developed a deep friendship and collaboration over the years. And here we see Humphrey in the middle of a objective structured clinical examination, putting a student through an examination. And this is the acute care unit at our teaching hospital for the between 700 and 750 bed hospital. There were 8 ICU beds in the hospital for peds, trauma, maternity, and internal medicine. And I worked as a clinical teacher here, along with Jan Beniet, who was the head of the acute care unit. We did much of our clinical teaching here. There are 8 ventilators, and the mortality in this unit is quite high. For internal medicine, it's around 50%. Pediatrics, it's much higher than that. It provided a clinical opportunity for instruction that was unparalleled. And I think for me, the biggest shift in frame shift is, as your chair calls it often, my frame shift was going from working in the ICU in North America, when many of the patients were older, in the 70s, 80s. People are getting Tabor valves in the 90s. And here, the patients were young. I don't have data in front of me. We did collect the data, but most of our patients were in their 20s to 40s. So these are young people, often with opportunistic infections, with low immune systems, or who have been traumatized, or children acute shock from dehydration and diarrhea. So they're very young, and that really comes to a point that we raise later, that many of the times when we come into a new area, we've been trained in a different system. It's not that you're not knowledgeable or confident, but you may have difficulty just adjusting to the way things are practiced. And I think even if you were shifting from Canada to the US, or Canada to Mexico, for instance, you really need, even though you may be a subject matter expert in the role of authority and very comfortable teaching, when you shift to a different environment, you really need to learn from others on how to efficiently work and how to efficiently teach. So the specific things that we worked on in this collaboration were development of the internal medicine curriculum. And one of the things, we lean heavily on McMaster and the long history that you have around medical education, and the long, just experience and transitioning from just pure didactic lectures to problem-based learning, and the challenges that go along with that, the number of instructors that are needed to willing instructors to affect a problem-based learning curriculum. We were able to have external examiners provided by McMaster University for both internal medicine and physiology, and this was done pro bono. But this provided us quite a bit of service that allowed us to ensure that the examinations and the other assessments, as well as our curriculum, that it met standards. And the people that we chose as external examiners at McMaster had extensive regional as well as international experience in the world authorities in their field. And so this was able to establish some credibility around the curriculum that we developed. I didn't understand at the time that despite the number of medical schools around the world, you actually have to develop your own curriculum for physiology or for internal medicine, and this is a problem and should be addressed. But the fact that there's not an open source, robust curriculum that can be deployed in new medical schools in low and medium income countries, it seems to me shocking that you would have to rewrite a physiology curriculum from scratch. And writing the curriculum is not the difficult part. Again, it's being able to come up with effective assessment that rolls over year after year after year, that hits the right points and it's fair and reflects the curriculum. It's a huge amount of work. We also really received tremendous amount of support around objective structured clinical examinations. To be able to, our assessment strategy was written exams, which we were able to prepare for ahead of time, but to ensure that the students had clinical confidence, we developed a system where we had, on-the-job type formative assessment where we're evaluating students as they're presenting patients, as they're assessing them, as they're resuscitating. But when it comes to the formative assessment, and especially at the end of the 6th year before they're entering internship, it was important to have an objective structured clinical exam. And so to do this for our classes range between earlier in 60s, later to over 100 in the cadre, each class that would graduate, and to be able to take them through the number of systems, we had to run these exams in parallel, which required at times 20 to 30, up to 40 examiners. So while we were able to recruit some of the local physicians to stand in as examiners, Christian Craker and Humphrey would come, but Christian would often show up with 6 or 7 trainees and specialists who had come on their own. They had arranged their own funding, they arranged their own travel, they arranged their own accommodation. And that comes to an important part. When you are there and you're in a position that I was in, not only was I responsible for maintaining the administrative aspects of the department, mentoring and performing research, for delivering the lectures, for doing bedside teaching, and for doing the assessment. Oftentimes, we would have visitors who would invite themselves or would be invited or would sometimes just show up on campus or who would tell us that they wanted to come for 3 months. And then after somebody who had agreed for them to come, they would drop a lot of administrative work onto us. So we would need to find their visas for them, need to find someplace for them to stay, help arrange their transport. And sometimes people wanted us to pay for their flights. And Christian Craker was adamant about making sure that part of the collaboration was handled by McMaster and did not drop onto us. And so it was always a question of what we needed. What help did we need? So it wasn't like saying we have a cardiologist who's going to come in and he's going to show you how to do radial stenting, or we want to give you a keynote lecture about anticoagulants. They would come and say, do you need any help? Or before they came, Crick would always ask me, do you need any help? Is there anything that we could do? And we would just tell them what we needed, and that's what we would do. But not only that, they would try to make sure that it happened in a way that didn't degrade our limited resources and actually added to it. And so instead of us having to do extra work, what we found is that a burden was taken off of us. And often when the team would come in, they because they would always come in with somebody who had been there before, there was never anybody who ever showed up by themselves who hadn't been there before. And trainees did not come by themselves. Trainees always came with a supervisor. And so this allowed them to jump right into the work and to be able to jump into the appropriate scope of work. So ahead of time, Christian Baker would assign lectures to trainees. They would prepare the lecture. We would go over them ahead of time and make sure they synced with our learning objectives. And then he would come, and then for perhaps a month or 5 weeks, they would do the entirety of the teaching, as well as lead much of the bedside teaching. And so during that time, it would allow me to be able to write grants, to be able to prepare for examinations, to do student mentorship, and also travel to other sites to be able to help prepare and work throughout that. And so I really see this is it was incredibly catalyzing. Same thing. Humphrey and Shirley would show up, and Humphrey, who and Shirley, both of them who are incredibly renowned in their fields, with hundreds of publications and international recognition in their field. Humphrey would come and sit next to me, and he would grade tests one by one. He would write test questions. He would meet with students. He would give basic lectures. He would do the grunt work that you would expect that somebody that him and Shirley perhaps wouldn't see as something that was worthy of their time. But that's what was happening, and it wasn't flashy, but it was extremely catalytic for us to be able to develop new programs and freed us up in ways that we never would have been allowed to otherwise.
Dr. Hunter, we've got about 2 minutes left in round, so I don't know if you can, maybe, I know you have a movie, we won't have time to watch that, so maybe we could just summarize, and then we could give a link for the movie to people who are going to watch it secondarily.
Sure, that sounds fine. And so I think actually, without going through my entire presentation around the research that we've done, just like to end by highlighting Dr. Helena Festus and Dr. Kruai, who both were able to come to Namibia, to come from Namibia to Hamilton, and to be able to see that. And it was wonderful for them to be able to experience Hamilton and to experience McMaster. And so I want to end just by thanking the department and for the support that they provided, and to highlight what how catalytic it is as an example of supporting through service rather than looking for individual acclaim and gratitude. And so I have deep thanks and gratitude to McMaster. I appreciate the chair for the invitation, and I will provide in the rest of the presentation a link to the movie.
Thanks very much. Great presentation, very inspiring. There's a lot of global health work that happens at many institutions, but your example, I think, is absolutely unique, that you contributed not only 10 years of your own time, but 10 years of your family's time to this enterprise. And again, as I said at the start, the prototypical example of somebody who walked the walk, because many of us talk the talk. So I'd like to take a moment just to thank you. Also thank the many people you've identified, Dr. Fulford, Dr. Craker, Dr. Chagla. I know that our current dean traveled to Namibia once, and so there was a lot of engagement and involvement, and hopefully it will continue. For the department members who are interested in getting involved in global health, some of you will be aware that Dr. Sonia Anand recently became the Associate Vice President for Global Health at McMaster, and would be a great resource for anybody who wants to reach out to find out how they can help with global health projects. And with that, we will get a link from Dr. Hunter so we can have the video that he's also wished to show up for people to enjoy. And I'd like to thank you and look forward to the regular grand round starting again next week with Dr. Verhofstadt and Dr. Azam. And then the next chair's grand rounds will be in 2 months. So thank you much, Dr. Hunter. That was inspiring and really a remarkable tour de force, looking at all of the incredible work that you did along with your colleagues in Namibia. Thank you very much.